I feel like in general, clinicians know to not rest all of their clinical judgment on vital signs. And it's not just, oh, everyone miraculously has a respiratory rate of 12, but to also take stock in that a lot of patients are likely not able to mount the response that you're looking for if they are in pain or septic or otherwise critically ill. In newborns, you're taught that it's not just if their temperature is high, but if it's critically low, that raises concern for sepsis, and that doesn't really go away, especially as they get older. But I've been taught as well to consider they might not have the ability to mount the response, a febrile response that you're looking for. If a patient is not tachycardic and you rule out PE, but then you realize they're on a host of beta blockers, that should give you pause. Or if their blood pressure is borderline low, but they're on a heck of a lot of midodrine, that might warrant more concern. But all of these things you need to consider it within the context of the patient in front of you, right? Like a super triathlon athlete might have a resting heart rate of 40, and that's completely normal for them. So when they come in with a heart rate of 80 and they tell you that's twice as high as it normally is, I would take a good amount of stock in that. Or if someone is subjectively tachypnic or short of breath, but their pulse ox looks normal, but they have a skin tone that looks different than mine, the pulse ox might read that differently. It's good to take into context the patient in front of you rather than the number.